It would help if I pressed show my screen, huh?
Oh, there it is.
There we go.
Good afternoon, Dr. Lynch. Thanks for joining us.
Afternoon.
This will be great. Your webinar was terrific.
For everyone that registered actually for the initial webinar, and then what we'll do again, guys, for those of you that are joining us right now, we will send you the registration link so that you can register for Dr. Lynch's upcoming event here in October in Seattle, Washington. It's going to be a 2-day event with actually, a 3-day, really, more of like a mastermind type meeting. I'll let Dr. Ben explain here shortly on Monday. Cocktails and hors d'oeuvres on Saturday. Dr. Lynch, you want to talk a little bit more about that?
Yes, those are being ironed out right now by the department at Bastyr for the continuing education. So that basically, in short, what's going to happen is there's going to be a select 20 to 30 physicians that will gather in a room, and we will be going over specific cases that we've chosen as a group, and we will go over them in detail. So I plan to have every attendee submit their cases, and then as a group we will choose which cases to present, and we'll all learn from those cases. And not only will they be just problem cases, but there'll be also success stories of very hard methylation products, or methylation patients, sorry. So again, that will happen as I get more information from Bastyr. I did meet with them yesterday for 2 hours, and it's still pending, but as soon as I know more, I will announce it. Sorry for the delay.
Great, okay. That's awesome. And then so what we'll do for all of you with us right now, and if you are listening to the recording, we'll send you out a link that you can register. This is time sensitive. There's, you announced this, 10 days ago, and Dr. Ben, and there was up to 300 people. Now there's only 80 seats left, right?
Yeah, it's flying. Bastyr told me they're stunned. It's actually changed from a seminar to a full-on conference now. Meals will be provided, and there'll be a meet and greet on Saturday night, which is great. So everybody in attendance will be able to exchange cards and learn more about each other and referrals. And there will be exhibitors there and everything. It's the largest event that Bastyr's actually ever had. So
wow,
crazy.
That's fantastic.
Yeah.
Simon Jim will definitely be there. We're happy to be a sponsor and excited that to be a part of it, and excited to have you back and to have everyone back with us today. Hope you're all having a fantastic Tuesday. It's Mike Mthfr and Bettina Newman with Zymogen here, and we have Dr. Ben Lynch with us, as you can tell, for a live Q&A. Dr. Ben is a naturopathic physician and undergraduate degree from University of Washington in cellular biology. So, Dr. Ben, we covered so much topic, so much information, content last week. What we wanted to do is, field some questions that a lot of our practitioners on the line, had, and so I guess we can go. I'm quite a few questions flying in here, but I wanted to make sure that for the people that got their questions in ahead of time last week, we can field some of those first. So I'll just start showing the slides, and we can hash through that. How does that sound?
Sounds good.
Given the higher incidence of cardiovascular issues, et cetera, with different methylate 5-MTHFR SNPs and variants, et cetera, what suggestions do you have for women wanting to that are taking birth control medications?
Fantastic question, and I think there's even some articles on mthfr.net about this, but I believe that natural birth control is first and foremost the best. So cycling, family planning is number one, and if you can do that with your patients, I think that's great. And if not, then I would be looking at, if it's a long-term part where they don't want to get pregnant, then you can consider an IUD, such as a copper IUD, if that's possible and feasible. I'm not sure if copper is the best choice, but or you can use the very slow-releasing small amount of hormone. Again, I don't know how good those are. My knowledge on birth control isn't as good as it should be. The other option is, of course, condoms and other birth control. If they are going to go on an oral contraceptive pill, use the ones that are not riddled with FDA warnings. There are some, I forget their names, where they have pretty butterflies flying around on TV for their commercials. But these are very high-dose hormones, and those can cause issues. Now we have to keep in mind it's not just MTHFR. If these women also have COMT variants, and they're also not metabolizing their estrogen levels, and these estrogen levels that they're getting from the birth control are also going to be somewhat elevated. Then you add on the glutathione SNPs, or their probiotics are insufficient, or their hepatic biotransformation is also insufficient for various reasons, then these oral contraceptives are going to be an issue. But in short, if you do have a woman on birth control pills, then obviously you need to monitor their hormone levels and their risk, and you can consider possibly baby aspirin or fish oils or krill oils, or supporting them with methylfolate and B12, because as you know, oral contraceptive pills are folate antagonists. And then another key point with this question is, once the couple wants to actually have a baby and they've been on oral contraceptives for quite some time, then you remove the birth control pills for at least 3 months, at least, and then you not heavily, but you properly restore them nutritionally and evaluate their hormone levels prior to them trying to conceive. Hope that helps.
Yeah, no, that's fantastic. And when you say nutritionally, can you get into a little bit more specifics on B12, forms of B12, folate? I mean, in your experience, let's say you don't know the genotype, or in another case, maybe you do know the genotype. Any broad advice that you can give on this topic?
Yes, thanks. Folinic acid or methylfolate are your two go-to sources for folate. Folic acid in itself is garbage. It literally is garbage. So there are too many steps that are required to convert folic acid into folinic acid and or methylfolate. And given the absorption issues of the population and antacids and other nutrient deficiencies, I highly recommend the use of folinic acid and or methylfolate. Now, methylfolate is a very useful nutrient, and so is folinic acid, and so both of those, or either of those, are important to consider, and good prenatals have that combination in them. And also utilizing methylcobalamin and or hydroxycobalamin or adenosylcobalamin are the forms of B12 that you should be leaning towards. Cyanocobalamin, no, that just should not be used. And I think those are the two main ones. And if looking at homocysteine levels is something to consider too, prior to women getting pregnant, but that's a whole nother webinar of pre-pregnancy support.
Right. A lot of practitioners ask questions about folinic acid or calcium folinate, and why don't certain companies? Why would you even put that in there? I get this question a lot, and you and I have had this discussion before over lunch that folinic acid is really heavily involved in DNA replication and RNA and all that. Can you get into that in a little bit more detail?
Yeah. So if you just give methylfolate, that's should be converted by the body back and recycled back into tetrahydrofolate, which then can go through the folate biosynthesis pathway and produce folinic acid. Now, that doesn't always happen for various reasons. One, you could be deficient in B12, or you can have inhibition of the MTR/MTRR enzyme, also known as methionine synthase, and there are various compounds which can inhibit methionine synthase, such as acetaldehyde from alcohol or yeast overgrowth. There can also be heavy metal inhibition. I don't know exactly which ones, but possibly mercury and lead are a problem here in methionine synthase. So if you just give methylfolate without folinic acid and the methionine synthase enzyme is not working properly, then you can be having a possible deficiency in folinic acid. And so utilizing both and bypassing MTR or the MTHFD, other folate metabolizing enzymes, is very important. Now, keep in mind, MTHFR is the very end enzyme in folate metabolism. There's multiple others, and if those are working slowly or having deficiency of various cofactors, then your ability to make folinic acid is also reduced. So I'm of the belief that we just need to assume that there's going to be some environmental burdens in every population, and we need to support them, not heavily, but somewhat with some nutrients such as folic acid and methylfolate. And you can also give leafy greens, uncooked leafy greens, and that also provides folic acid to some degree and methylfolate to some degree. And I say to some degree because it's not measured in foods, these two nutrients.
Mm-hmm. All right, fantastic. So there's some questions on variances and not necessarily correlations, both high and low serum B12 in patients with MTHFR SNPs. What would you say about this?
Okay, now high and low serum B12 levels, there's a lot of ifs or ands in this question. Now, if you have a high B12 level, a simple comment with that would be one you're over supplementing, obviously. Two, you could be having a folate deficiency, especially methylfolate, because methylfolate is what is the substrate needed to drive the methionine synthase. And methionine synthase takes the methylfolate and will then work in conjunction with methylcobalamin and utilize it. Now, if you're lacking in methylfolate, then you are not using the methylcobalamin as well as you should be. Thus, the levels are falsely elevated. That's one. Two, you might have an inhibition in methionine synthase for some reason, perhaps heavy metals inhibiting methionine synthase, so it's not working as well as it should be. Again, due to yeast overgrowth, acetaldehyde release, alcohol inhibition of again from the acetaldehyde, or you've got heavy metal inhibition or various drugs inhibiting that pathway as well. So you can get falsely elevated. Nitrous oxide does inhibit methionine synthase also, and nitrous oxide is commonly used in dental offices, and I am not sure if that can falsely elevate B12 levels. I don't think it would, but it would be interesting to see if that was the case. But I do know that if you're preloading with methionine and methylcobalamin and methylfolate in those receiving nitrous oxide, they don't get the side effects. Now, another reason for elevated serum B12 is there might be transcobalamin deficiencies. Now, transcobalamin is the carrier protein which carries the B12 around the body and delivers it intracellularly. Now, we know about the proteins and intrinsic factors in gut absorption, but we don't commonly understand that B12, once it is finally absorbed, it will need a carrier protein to deliver it. So there might be a deficiency in transcobalamin. There are some very old research studies that point out that lithium levels are commonly low in those with deficient transcobalamin levels. I've tried to pull those studies in full, but I've been unavailable to do that. So utilizing lithium may support that. And also I think that's a big one. And while we're on the topic of B12 levels being elevated, I also want to mention that there's a common SNP. I don't have the ID of it, but methylcobalamin has to be converted to adenosylcobalamin by an enzyme that is located in the mitochondria. So if your mitochondria are not working very well, then adenosylcobalamin, which is a derivative of methylcobalamin, may be low. So adenosylcobalamin may be very useful in those with mitochondrial dysfunction.
So chronic fatigue syndrome, low energy states, would those be the type of patients that you would think might be would benefit
Yes.
from adenosylcobalamin?
Yes. Yeah.
Fantastic. I just skipped ahead a little bit. We'll go back, but just to try and categorize these questions, B12, knock them all out at once. Some different questions here. I don't know who Defs is, but there's research evidently stating that you should recommend methylfolate before methyl B12 or methyl B12 before folate. What would you suggest on that?
Yeah, this is in reference to the PhD of Richard Deeth, a brilliant guy. He's a main dopamine researcher in the autism community, and he brought up a great point, which I recently learned about a month or so ago. And so you have cobalamins, and they have different, I don't know, valences or whatever the term is, but you have cobalamin 1, 2, and 3. And cobalamin 1 is very, very reactive, and it can become a very potent radical. So, as I pointed out in the last webinar, so that can happen if one is deficient in methylfolate. So if somebody takes methylcobalamin or cyanocobalamin or hydroxycobalamin or any cobalamin and they get side effects from it, it may be because they're deficient in methylfolate. Now, my initial thought a couple of years ago was, in order to prevent methyl trapping, we need to give methylcobalamin first, so we're not trapping the methylfolate into the system and not being able to utilize it. So, but in looking at Dr. Dee's work, that may be contraindicated in those who don't have adequate methylfolate in the beginning. So, because you're going to be then oxidizing the cobalamin. So, in short, I would be utilizing both at the same time in order to address both issues. Because if you give methylfolate first and they're B12 deficient, you're going to be methyl trapping. If you give B12 and they're deficient in methylfolate, you're going to be oxidizing and causing free radicals from the cobalamin. If you give both at the same time, you're going to be addressing both of those issues and possibly reducing the side effects from either one. Now, however, as mentioned last time, you cannot always give methylfolate and methylcobalamin as a first-line offensive move in your patient, because they can greatly flare for various reasons. So I don't want to get into that, but you can. I would probably say you have a 60% chance of being having a good success rate with your patient if they're not too old and they're not too severe in symptoms. If you grab the methylfolate methylcobalamin combination and work with them that way. Now the next question here: B12 test versus methylmalonic lab test, which or both should be used? I would say the urinary methylmalonic acid test, according to my research and experience, is the best, and because it looks at the mitochondrial levels also of B12, because if you have elevated methylmalonic acid, then you are going to be low in adenosylcobalamin, and that is a big point. Now, looking at serum B12, I think that's a pretty bad test. To me, I think that's looking like for thyroid with TSH. I don't think it's a very functionally minded test. Serum B12, there's a lot of nuances with that. I mean, it can be falsely elevated, falsely low, and various reasons. And I'm trying to find and put together a lab test which can help really pinpoint B12 deficiencies, because they can be masked, as you know, by folate, especially folic acid, not methylfolate. Actually, you can't mask B12 deficiency with methylfolate, but you can with folic acid. So, moving on. Does niacinamide also act as a methyl sink? And is that niacin or niacinamide or NADH? Great question. Now, niacinamide and niacin, how you phrase these is like saying folate. When you say the word folate, what do you mean? Do you mean folic acid, folinic acid, methylfolate, tetrahydrofolate, and so on? Now, when you say niacin, what are you referring to? I am assuming that you're referring niacin as nicotinic acid. And nicotinic acid and niacinamide both use up SAMe. So as a methyl quote-unquote sink, yes, both of these will utilize SAMe. How much SAMe is utilized by niacin derivatives, I am not sure. It's definitely not as much as creatine formation, because we know that 40 to 70% of SAMe is needed to produce creatine, which is pretty remarkable on a daily basis. And if you are giving high-dose niacin or niacinamide or nicotinic acid, then you will be lowering the levels of SAMe in your patient. Now, what is NADH? NADH is a utilizes nicotinic acid and niacinamide or inositol hexanicotinate as well to be produced. Now, I'm currently researching NADH intensively. I mean, I was at the medical school library last night. I pulled another 20 studies on NAD formation and synthesis. And I do know that nicotinic acid and niacinamide production or utilization or transformation to NAD is not very efficient. So one might have to supplement directly with NAD if there are some biochemical issues or biochemical pathway issues or insufficiencies. So I'm currently researching that right now. So I can't answer you if NADH is a methyl sync, but I can tell you that NAD is exquisitely important, and my stance on use of niacin is still cautionary, that you can't be giving high-dose nicotinic acid in those just to lower cholesterol without supporting SAMe levels or methylation. Because if you're just giving, say 3 grams a day of niacinamide to your patients, or nicotinic acid rather, to lower LDL levels, then you may be considering the use of betaine or TMG or SAMe to support SAMe levels. And there was a research study that I saw that directly recommended the use of TMG in conjunction with high-dose niacin therapies in order to lower triglycerides and cholesterols. So I would be considering that.
Fantastic.
Yeah, go ahead.
Okay, can you supplement with phosphatidylcholine, and then also maybe this would be a good time to talk about creatine as well and other metabolites off of the SAMe type pathway?
Sure, good question. Yes, you can supplement directly with phosphatidylcholine, absolutely. I would be careful if you are a person who takes the phosphatidylcholine and you experience more anxiety or insomnia. Phosphatidylcholine does provide choline, which then can provide acetylcholine. Acetylcholine is a neurotransmitter that creates you to be more alert. So I would be cautious with that, and it can also cause more possibly muscle pain or muscle fatigue. So I would be using a kind of a phospholipid blend in order to provide the phosphatidylcholine. Some people can use lecithin as well if you want. The concentration, the amount of lecithin you would have to take is pretty significant. You can also eat eggs if you can tolerate eggs, because eggs are a brilliant source of choline. And if you go to nutritiondata.self.com, you can go in there and you can type in, there's a nutrient search tool, and you can type in choline, and you can see which foods are very high in choline. And you'll see that soy is, and you'll also see that eggs are as well. But in short, yes, you can supplement with phosphatidylcholine. How can you support the production of phosphatidylcholine? Well, you can eat eggs or foods high in choline. You also can take betaine, I believe, TMG. I don't think that's too far downstream. It might be too far downstream, actually, but I'm not positive on that. But it may recycle back into choline. But I could be wrong. I don't have the graph in front of me. Now, in order for your body to make phosphatidylcholine, it does take choline to do that. And I think betaine converts into choline, or it could be vice versa. Again, I don't have the path in front of me, sorry. And then in order to convert the choline into phosphatidylcholine, it requires an enzyme which is called phosphatidylethylamine methyltransferase, and that requires SAMe. So it requires 3 SAMe molecules to make one component of phosphatidylcholine. So it is pretty demanding for SAMe to produce phosphatidylcholine. And there are seemingly pretty prevalent enzymatic issues, or SNPs rather, in the PEMT enzyme. So my wife, for example, has a PEMT SNP homozygous, so her ability to produce phosphatidylcholine is pretty significant. And that is really an important one to look at for women who are getting pregnant or during pregnancy, or even breastfeeding, because choline is pretty commonly deficient in those breastfeeding as well. So phosphocholine is a very, very important nutrient. Now to address Mike's comment also about other really important elements produced from SAMe, CoQ10 is a really big one, carnitine, creatine. So all these are very important. Also, melatonin and histamine degradation are also needed by SAMe, along with epinephrine synthesis as well, and also eliminating various neurotransmitters such as dopamine and epinephrine is also used up by SAMe and others. So SAMe is really, really important, and obviously to produce phosphatidylcholine it does require SAMe. And again, to reiterate the point from last week's webinar, creatine is the most demanding of all, using up 40 to 70% of your SAMe in order to produce that, because you are excreting creatinine every day on a daily basis, multiple times a day, every time you urinate. So you have to create your creatine on a daily basis. So if you have kidney problems, creatine is going to be low, but you have to be very important. You have to be careful with creatine supplementation during kidney failure. So that's another issue.
Fantastic. Let's see here. Let's skip ahead. Okay, let's get into the mitochondria a little bit. A couple questions here. How do you support the mitochondria? It's kind of a blanket statement. And what are your views on IV NAD for cellular health and mitochondrial function?
Okay, so I'll answer the second one first. My views on IV NAD for cell health and mitochondria, absolutely critical. NAD is very, very critically important. And again, my knowledge of this is increasing on a daily basis, as long as I'm not having back-to-back webinars all the time. And so, but NAD is critically important for cellular health because NAD is a key component of recycling oxidized glutathione on the mitochondrial intermembrane space. So if you are supplementing with glutathione, then if you are deficient in NAD, then you are having oxidized glutathione inside your mitochondria and it cannot get out. So I want to repeat that. If you are deficient in NAD and you are even supplementing with glutathione, or you're not supplementing glutathione and your glutathione levels according to your lab are quote unquote okay, they may be oxidized because the lab is not necessarily looking at oxidized glutathione in the inner mitochondrial space. And NAD is a critical component, and without NAD you are not driving the glutathione reductase enzyme in order to recycle oxidized glutathione back into reduced glutathione in the inner mitochondrial space. So it's very, very important. And also oxidized glutathione will inhibit complex 1 of the mitochondria. So if that happens, then your NAD production is also low because complex 1 helps produce NAD, or I think it helps produce NAD. I know the Krebs cycle does, absolutely, and I think that complex 1 does as well. But either way, NAD does support complex 1 of the mitochondria significantly along with CoQ10. So supporting the mitochondria does require NAD usage along with CoQ10, along with carnitine and phosphatidylcholine. And if you are along with glutathione, glutathione is the #1 component for mitochondrial preservation and health, because if you're deficient in glutathione, especially reduced glutathione, obviously your mitochondria will start triggering compounds which will trigger cell death, and the entire cell will die. If the mitochondria die in the cell, then that causes the entire cell to die, and that causes a whole bunch of cascade inflammatory responses, which causes further oxidative stress, which causes further mitochondrial stress, which causes further cell death, and the cascade keeps going. So mitochondrial health, in my opinion, are the #1 things to start with immediately. You don't start with MTHFR. If a client or patient has MTHFR, then you most likely know then they will have a mitochondrial deficiency of some sort. So you need to support that And if your mitochondrial cell membranes are not healthy because you have deficient phosphotylcholine due to deficient SAMe synthesis because methylfolate is not being pushed through the system, or because of MTHFR or dietary issues or other inhibitory steps, then your cell membranes are going to start getting destroyed, and that causes also further stress. Now, a key point also that I want to talk about with mitochondria is, in order, well, let me back up a little bit. As I mentioned, glutathione is the key nutrient for mitochondrial health and cell health. So if you look at the cell, the volume of the cell is the cytosol, which is inside the cell, that contains most of the glutathione by volume. But if you look at the organelle, the mitochondrial organelle inside the cell, inside the cytosol, then by weight and by volume, the mitochondria hold the most concentration of glutathione. And so you have the cell membrane of the cell, so glutathione has got to get through that, and it has to stay in there healthfully. So you have phosphatidylcholine and other fatty acids contributing to cellular membrane health. Then the glutathione gets into the cell, but then it has to penetrate through the mitochondrial outer membrane and get into the mitochondrial inner membrane inside the mitochondria. And how does that happen? It happens through active transport. And again, if the cell membranes of the mitochondria are screwed up, then those channel proteins are not going to be in existence, and you are not going to be able to funnel glutathione inside the mitochondria, and then you will have just a buildup of oxidized glutathione, especially in the presence of a lack of NAD. So it's very complicated and very, very important, but that's basically how you support the mitochondria through phosphatidylcholine, CoQ10, carnitine, and creatinine, and not drinking alcohol and all these other things which damage the mitochondria. And there are a lot of other medications which also damage the mitochondria, like fluoroquinolones are really, really toxic. Again, this is just another topic in of its own, but IV NAD is great, and I'm working on an NAD formulation right now. I just pulled the trigger actually this morning on a NAD product. I'm not going to reveal any more than that, but I feel it's going to be really, really, really critical for people and provide a lot of great results.
That's fantastic. And what would you recommend for, in addition to NAD, for supporting the mitochondria?
Well, alpha-ketoglutarate is needed, and a CoQ10, carnitine, creatinine, ribose is a really, really big one. Then you've got resveratrol, green tea extracts. You've got, you guys have a Nrf2 activator, right? Zymogen?
We do. We have the, which includes some of the phytochemicals that you mentioned, the green tea, and then the 95% curcuminoid material, and pterostilbene, which is a resveratrol-like compound that has really good bioavailability data and pharmacokinetics in comparison to resveratrol. We have the mitochondrial renewal kit that features the L-arginine bound to alpha-ketoglutarate that you mentioned, the controlled release 600 milligrams alpha-lipoic acid. So a nice packet, with all these different things, really good feedback. And then, Dr. Lynch, I don't know if you and I have really talked much about it, but a lot of good data on the acetylated oral glutathione. So we Zymogen calls that S-acetylglutathione. And there's actually data showing that this has higher affinity to cross into different cell membranes, particularly the mitochondria. So that could be another, product that clinicians can utilize in these mitochondrial challenged patients.
Okay, great. Good points.
All right. So let's get on to lab testing. There was a lot of questions here on lab testing. What's your favorite lab test? And then questions are flying in now. Which SNPs do you look at first and which do you address first? But just overall, what labs do you like the best?
Well, for genetic testing, there's a lot of ethical considerations here, and it depends on the readiness of the patient. So if your patient is totally gung-ho and understands what a genetic test is going to show them, then I would be recommending 23andMe right away and getting that done. And the reason being, one, it's cheap; two, it's easily available; three, it's easy to get done. You just spit 5 ml in a tube and send it in, and they get the results. If they're not ready uh, mentally to see that they are indeed a mutant, like we all are, and having increased risk of various conditions like Alzheimer's and cancer and breast cancer and so on, then I would be more focused on a smaller panel such as Genova, detoxigenomics, or cardiogenomics panel, or looking at just an MTHFR test. And looking, if you're just testing for MTHFR, then I'd be using any lab test now, or molecular testing labs, or SpectraCell, or Quest, or LabCorp. All these guys provide MTHFR. And Baylor, that was provided information to me by Dr. Rindy. That's a very great way, inexpensive way for people to get their MTHFR done as well. And that's on another presentation that I've done, and Dr. Rindy, I think, also has a information on how to get that too, but it's just Baylor Research Institute, I believe. But you have to keep in mind what's going to happen when you show your patient the genetic SNPs on a test on a piece of paper that you lay down in front of them. It's very scary. And as long as you have a very heart-to-heart conversation and they get it prior to ordering these tests, then I recommend getting it done. But I would also highly recommend having them watch the video by Dr. Bruce Lipton, who's very empowering and talks about how your perception of the environment controls your own internal environment and thus genetic expression, and that he is a huge influence on me, and I think that's a very, very empowering video, and I think all patients should watch that. And I would, prior to any genetic testing, I would have them watch that Bruce Lipton video. And on the mthfr.net website, if you type in Bruce Lipton in the search box, you'll see an article there, and there's a YouTube video that links right to Bruce Lipton, his new biology talk, and also his book on new biology. But that's in a nutshell the genetic test that I recommend. And I use on a daily basis. Now, when you get your 23andMe test back, it's not very informative. It shows your relative risk for prostate cancer and Alzheimer's and breast cancer and all that, which is great, but it doesn't really give you any insight of other genes that I've been talking about unless you know how to identify RSID numbers and look up different genes. And so I've helped create a report that's provided by mthfrsupport.com that she takes your raw data privately and that you export from 23andMe, you import it into mthfrsupport.net's system, and it spits out a bunch of like over another 100 and so genes that you look at. It includes PEMT and CUMT and MAO-A and glutathione SNPs and mitochondrial SNPs and thyroid issues and immune support and a bunch of other ones. The creatinine SNP, GAMT, is really important. That's in there. Cytochrome P450 SNPs for detoxification. Those are also in there. And there's also geneticgenie.org. You can also download your raw data from 23andMe report once you get it, and you can plug that into the geneticgenie.org for a donation, and you can get your detoxigenomic profile from them, because the detoxigenomic profile is basically provided by 23andMe. They also have the YASCO profile available there too. Amy Yasko is another. She has a PhD in microbiology and biochemistry, I believe, and she has her ND from online program, I believe, and she's pretty well versed in genetic SNPs also. And the geneticgenie.org has her profile there that you can also run at a great discount. So those ones I recommend.
Fabulous. Now, if someone has associated SNPs like CBS and COMT and all that, in addition to MTHFR SNPs, which SNPs do you like to advise practitioners to manage first? Is there a type of hierarchy here?
I go by symptoms. I'm really huge on history, and that's also a big issue when you order genetic testing. If you as a physician recommend a genetic test to a patient and you get all these genes back and you start treating the genes and not the patient, you're not going to get anywhere. It's not doing anyone service. Just because somebody has a CBS or COMT or MTHFR does not necessarily mean that those genes are a problem. So you can, in time, and hopefully in this conference that's coming up in October, you will be able to walk out of there and start applying things based upon history. So if you see a CBS SNP and COMT SNP and MTHFR SNP and MAO-A and GAMT and PEMT, and you're thinking, oh God, this patient is a mess, then where do you start? You start the same way that you were trained to. You start with a thorough history, and you need to evaluate when it started, how it started, what they're worse with, what they're better with, and all these different things. And that's where you start. Now, say you've done all that, and you've done all the homework, and you've reached your capacity to move on further without genetic testing. One, I don't think that's the case. I think a lot of physicians need to learn how to take a better history and start working with it, because a lot of my clients got better just off of history, and that's it. And then I would say you need to start supporting the mitochondria first and the cell membranes first, and that means that you need to start supporting CBS first, or oxidative stress. So anything that has to do with oxidative stress, like GSMT1, the glutathione SNP, or cytochrome P450 SNPs that are increasing the phase 1 detoxification too fast and possibly causing more reactive metabolites and more oxidative stress. So cytochrome P450s can be something to address first. But there's no real which gene to start with first, in my opinion. It all depends on where the patient is and how to go about that. But if you were to pick a gene, I would say the CBS SNP along with the detoxification SNPs, especially the phase 1 SNPs that are pushing them too fast and causing more reactive metabolites like formaldehyde or acetaldehyde or others. Like acetaminophen creates a very, very reactive phase 1 metabolite. After it goes through phase 1, acetaminophen is very damaging. And lab testing to identify these things is also important. And the lab testing is important because you need to see what these genes are expressing. It's not just because you have the gene. Again, it doesn't mean its phenotype is being expressed. So you need to look at what's on the paper in the lab. So labs like Oxidative Stress 2.0 by Genova, the blood option is really, really good. Also, the RBC fatty acid test is also really important. So those are two, but that's by doctor's data, and others have that as well. Those are two key labs. So next question. Do you have any comments on that, Mike, before I keep on going?
Well, I thought fish oils cause cancer, Dr. Lynch. I'm just kidding. No, it was a joke from that study last week on prostate cancer where they actually, the patients weren't even really taking fish oil. They kind of a unique study. Any comments on that one?
Can you repeat that one more time? Sorry.
Oh, it was just a joke, but the prostate cancer association with fish oil last week, and it turns out the patients weren't even taking fish oil.
Right. Yeah, so I highly recommend that everybody stops fish oil immediately because that was a very well done study. Yeah. So you got to start consuming arachidonic acid. I think that'll be much better.
Yeah, corn oil instead, I think.
Yeah, definitely. Sweetened with aspartame.
Nice. Okay, we're getting here towards the end of the time, but a couple questions just came in here. What is the frequency in the population of heterozygous MTHFR mutation ANC combined with double COMT mutation?
Don't know. Good question. I don't know. I can tell you that I know the prevalence of a single SNP of the 677 MTHFR variant is about 45% prevalence in the population, in the overall general population. There's a free video on mthfr.net that shows a really nice graph of prevalence that varies in different ethnic groups, and you can look at that for the 677 homozygous variant. But the COMT prevalence, I'm not sure. It's something I'd really like to have a researcher for.
Sure. Yeah. A question came in as we were talking about glutathione, and then right when we transitioned about, what's the efficacy of using NAC and glycine and cysteine and all the cofactors required for glutathione production. And I just wanted to make a quick comment. There was actually a clinical study that looked at the milligrams needed of glycine and cysteine needed to raise glutathione levels in the serum in elderly patients, and it was actually quite high, 131 milligrams per kilo of each glycine, and then I think it was 110 milligrams per kilo of body weight on cysteine. So if you do the math, you basically add a 0 to your body weight, and that's how much glycine and cysteine, respectively, you would need in milligrams. So quite a significant number, not to say that these nutrients are not beneficial, but to really see, in this population, it was elderly women, to notice appreciable changes in glutathione, they needed a quite significant amount of cysteine and glycine. Any comments on that, Dr. Lynch?
Yeah, I think those nutrients are great. Then you're also going to need things like alpha-ketoglutarate and B6 and riboflavin and niacin and everything else along with those, right, in order to recycle it back and to reduce glutathione. I think that glycine is also an inhibitory neurotransmitter. So you have to, if you're giving such high dose glycine, what effects are you going to get neurologically in the elderly population with that, right? I mean, I don't know if that is such a wise move to give the substrate needed to produce glutathione in the elderly. I would think just giving the glutathione or S-acetylglutathione directly would be important. And again, we talk about glutathione increasing on labs, but really how much mitochondrial glutathione are we getting? Because I don't think the labs are evaluating that. So, and you can tell by the levels of lipid peroxidation. If there is high lipid peroxidation in your patient, then you know right away that there is deficient mitochondrial reduced glutathione availability. And I think, at least in the elderly population, or those who are ill, to give NAD and glutathione right away as much as you can, as long as they tolerate it. If you can't give glutathione right away, if there's high oxidative stress, because that oxidative stress is just going to just destroy the glutathione immediately and make it worse. But substrates, and I think in the general healthy population, knock on wood, such as myself or Mike, or those who are generally healthy, I think glutathione precursors are great. I don't think you need to spend the extra money on taking glutathione directly. But again, how much do you have to take in order for that to happen? I don't know.
Mm-hmm. Okay. Good. We've talked about pretty much every B vitamin today, except for riboflavin. I know that's one of your favorites. Can you get into that in the correlation with different folate SNPs?
Yeah, so if I'm hypothyroid and have this 677 variant, should I supplement with riboflavin? If so, how much? I'm not a fan of these really narrow questions, because I'm a very big picture thinker and applier, so I would never just recommend B2 and methylfolate and B12 for somebody who's hypothyroid. But to answer this question, riboflavin is very important. And there are studies that link hypothyroidism with somehow interfering with, hypothyroidism somehow interfering with riboflavin and thus the MTHFR enzyme. And there are also plenty of studies that link hyperthyroidism with elevated homocysteine. So it would make sense that supporting those who are hypothyroid with riboflavin would be useful because riboflavin is a negative cofactor for the MTHFR enzyme. And whether or not that would show benefit clinically, I am not sure. Looking at the research, yes, obviously you need to be addressing other things as well. But yeah, I would be looking at riboflavin in those who are hypothyroid, and I'd also be evaluating their homocysteine levels and their MTHFR status.
Okay, awesome. All right, SAMe is expensive. Can you accomplish increasing SAMe levels with methionine supplementation?
You can, but you have to have the methionine, the MAT enzyme working well, for one, and there are SNPs in that. I don't know the prevalence or incidence of it. And you also need to have adequate levels of magnesium, and you need to have adequate levels of ATP, and I'm not sure of other cofactors beyond that, but I do know creatine, ATP, ATP, magnesium, and methionine, and a functioning MAT enzyme are needed for this in order to convert methionine into SAMe. And you can always try and see how you feel. And there are issues in studies showing that SAMe can increase homocysteine. Yes, they can, but as long as you're taking B6 and you're at least eating B6 supplementation and B6 and your folate to recycle that back around, or your betaine TMG, you're going to be fine. It's just something to monitor. And I think Dr. Hassi, he's an MD that did a presentation with Mike some time ago. He talked about the incidence of elevated homocysteine levels from SAMe supplementation or methionine supplementation. It can exist, but you just have to monitor it and be careful. But in short, you can try supplementing with methionine to see if your SAMe levels will, clinically, they can go up, and you can check that through doctors' data, methylation pathways panel, and they do check the SAM-SAW ratio, and they also show methionine levels on there and cystathionine, and some other markers like cysteine. So that's useful to check, along with homocysteine, of course.
Okay. Sounds good. This was a related question that just came in. What is the role of sulfur in food and MSM in the methylation cycle?
Yeah, huge. So the role of sulfur in food in the methylation cycle is really important, because sulfur is a precursor. I mean, sulfur foods contain cysteine, and cysteine is the main substrate for glutathione. So if you're not eating sulfur-containing foods, then you're not able to produce your glutathione. But and cysteine or sulfur groups are also found in a whole bunch of other proteins in the body, and so eating your sulfur foods are critically important. And I know a lot of people have issues with sulfur foods, and I think that has to do with the level of oxidative stress and glutathione levels, because you can have sulfhydryl radicals which are very damaging in the system. So you need to be able to quench those, and that's done by glutathione. But glutathione itself is a sulfur compound, and it can also be reactive by itself. So again, we're going back to NAD and recycling of glutathione and all that. But in short, sulfur foods are fantastic as long as you tolerate them. Now, if you are not tolerating them, perhaps you are low in the mineral molybdenum. That's a great one to reach for. Molybdenum glycinate is a good form. It's very well absorbed. Glycine does contain sulfur, but the molybdenum should take care of that for you. And it seems to be much better absorbed than the molybdenum picolinate and the molybdenum that's bound to ammonia from another supplier. So clinically, I've seen the molybdenum glycinate much more effective in helping to process the sulfur bonds. Then you have sulfonotransferases, which are a key enzymatic process in order to help process sulfurs, and sirtuins are also really important for this as well. Big topic, general question, hard to answer.
Yeah, no, I agree 100%. This one came in, I think it's really good. I've heard this question asked to me a lot, and I know you talked about it in the webinar, so it would be good to readdress. But what does methylation block mean? And, I have patients that get neuropsychiatric symptoms from methylcobalamin, CME, and more than 800 micrograms of methylfolate.
Okay. So methyl block is you're right, it's a bad term. It's a lazy term. And it's basically just saying that there's some form of inhibition in methylation along the transmethylation pathway or the shortcut route. And I would say that when people say a methyl block, some people are using it inappropriately, and I may even be using it inappropriately sometimes. You can be saying that a byproduct of methylation, SAW, acetylhomocysteine, is a big methyl block, and that's a byproduct of the methylation cycle. And that inhibits outward of and beyond of the immediate methylation pathway. So SAW will inhibit any DNA methyltransferase enzyme in the body, and there's over 200 of them. So COMT being one of them. And so if there is a quote-unquote methylation block of COMT, and that methylation block would be SAW, SAH, acetylhomocysteine, then you need to remove that by giving SAMe. Okay, so what if you give SAMe or too much? Then your COMT will be not inhibited, but what if they have a COMT mutation, or SNP rather, then they're not going to be able to process those neurotransmitters as well, and those will accumulate if you give too much SAMe. So it's a dose specific for each patient, and it varies day to day. So if your patient is really stressed out on one day, then they may need more niacin, or they may need more SAMe, or actually anxiety would probably be needing more niacin rather than SAMe, and depression probably needing more SAMe. So I don't recommend using the same amount of supplementation on a daily basis. And let me give a prime example of this. There's an article on mthfr.net as a great example of this. If you type in overmethylation on the mthfr.net, you can just type in overmethylation, undermethylation. There's an article there that shows my kind of dialogue between this one individual who was taking methylfolate for some period of time and methylcobalamin, and they felt much better, but then they kept taking the same dose and they got way worse, and he was taking some medications which also upregulated serotonin recycling and so on, and so he got much worse, and he started pulsing it and taking niacin and not taking it every day and taking less doses, and that improved. So with this doctor's patient, I would say you can get, if you give methylfolate, methylcobalamin, your patients feel better at first and they feel much worse after. You could be producing too much neurotransmitters for them faster than you can eliminate, or you're causing an increased oxidative load, which is causing increased stress, which may be stimulating the kynurenine pathway and increased NMDA firing. So that would be something also to be looking at. It's just not a simple picture, but I do not recommend giving the same amount every day. If somebody is feeling really good that day, then they don't take any of their B12 or their methylfolate. If they're starting to feel a bit sad or depressed, then they can reach for it and take some. If they're feeling more anxious, they can take some niacin. And this varies on a day-to-day basis. I don't take methylfolate every day. I'm compound heterozygous. I have one 677 variant of MTHFR, and I have one 1298 variant, and I have other folate issues as well. And I know that when to take methylfolate and when not to, and it's just something that your patients and you as a physician have to learn.
Okay, sounds good. Well, as we wrap this up, Dr. Lynch, I know this is something that you've looked at, on mthfr.net, and you and I have talked about the type of methylfolate that you recommend and the quadrifolic. And from your research, what have you found on this raw material?
Well, quadrifolic is a great nutrient, and it seems to be very well absorbed, and the response clinically is good. I also like that it's not bound to calcium. Calcium is not the best of nutrients, especially in those who have mitochondrial dysfunction, because you're already getting an influx of calcium. Obviously, you're not getting that much calcium in a microgram dose of methylfolate, but still something to consider. The labs, the research on quadrifolate also seems to be quite solid. I think Mike is more knowledgeable on quadrifolic compared to metafolin than I am at this point. But I am personally switching from metafolin to quadrifolic based upon what I'm seeing in the research and some of the experiences clinically as well.
Sure. Yeah, basically, the bottom line, like you said, the calcium bound to the L5 methylfolate, that bond is not as stable, and shelf stability and then bioavailability is not as great as when you get this vegetable-derived calcium molecule that you're going to find in the quadrifolic version of the 5-MTHF. That's where you're going to get superior bioavailability, better shelf stability, and then greater absorption. So that's what's unique there. And we'll go ahead and end this. And for those of you that didn't make it on the line earlier, we did mention a seminar, Dr. Lynch, and you want to just mention again, there's only 80 seats left. You're going to get into this in a lot more detail. I'll send you guys a link, but any other comments you want to add to that seminar?
Yeah, briefly, it's just going quickly. I posted on July 5th or something, and it's already almost gone. Out of 280 seats or so. And I also want to state that lunches are now provided and snacks are provided. It's turned into a full-blown conference. I think it's going to be excellent. There's MDs, NDs, DCs, nutritionists, psychiatrists, a whole blend of like-minded professionals are going to be there. And I think the meet and greet on Saturday might be one of the best meet and greets I've ever been in, because it's going to have all these like-minded professionals in one room, and we're going to have some methylation disturbances because beer and wine will be served as well, but at least we know how to bypass that problem, right?
Right.
So, but I think it's just going to be a fantastic group of people, and I'm really going to have a lot of time to get into the nuts and bolts of all the biochemistry and all the nuances. So you guys will not have these 1 hour bits and pieces and taping them together with Scotch tape and trying to piece it together, because frankly it's useful, but it leaves more questions than answers, and that's why I am dedicating 15 hours on stage at Bastille. I don't know how that's going to work. I have to suck on some lozenges or something. But I really am excited, because I'm actually going to be able to really give a lot of the interactions between these pathways and all the nuances and of why some people react to the way they do and why some don't. So I'm excited for it, and hope to see you there. And if you can't make it, there will be a DVD provided after the conference is done, so you'll be able to obtain that. So that is also an option. And either way, there will be plenty more seminars and conferences in the future, and my knowledge is always increasing, and I correct myself if I'm wrong, and I try not to be wrong, but sometimes you are, and I'll provide the latest research in October. I look forward to seeing you guys there, and thanks, Mike, for hosting me here with this as well.
Fantastic. Yeah, we look forward to being there in October. And for Zymogen Wholesale customers, we do have a special on some of our top methylation support products, up to 25% off on 36 bottles or more. Dr. Lynch, thanks again. This was a wonderful Q&A, and we look forward to having you back on sometime soon.
Yep. Thank you, Mike.